I'm Sagar Lonial, and I'm here with Blood Cancers Today, and we're going to talk a little bit about the impact of recent data on CAR T cells and how to incorporate them into your daily practice. I'm joined by two esteemed colleagues.
My name is Noopur Raje. I work at the Massachusetts General Hospital Cancer Center in Boston, and I'm really excited to be talking about the T-cell directed therapies in multiple myeloma today.
And I'm Krina Patel. I'm an associate professor at MD Anderson Cancer Center in Houston, and CAR T is my favorite thing. I'm not biased at all, so thank you for inviting me.
Krina, I know that you at SOHO presented some data on the impact of CARs on current standards of care. Do you want to give us a little bit of that snapshot?
Sure. Yeah, I think, again, having more therapies for myeloma is always great, but the difference for CAR T really has been that quality of life piece for patients, right? That it's a one and done. Quality of life for that first week when they're getting lymphodepletion, they're getting the cells, outpatient, inpatient. It does take away a little bit that they have to be near the center for about 3-4 weeks. But after that, that quality of life really jumps up, right, compared to the continuous therapy when patients are on. And we have studies that show that now. And I will say that because of that, we have patients that are asking for it, right? Specifically like, hey, can you get me a CAR T so I can get time off so I can go do this or that? I've had patients go back to work, right? So I think it's been phenomenal to have that, but I think the sequencing question comes up. How do we give it? The access issue, which I know everyone's working on to make sure we get enough slots for patients. But even the ability to do this at your centers, right? This is a little bit more high maintenance therapy. It's not off the shelf. You have to collect people. You have to send it off. You have to make sure these patients are okay 4 to 8 weeks while you wait for the cells. Make sure their myeloma is okay, and then bring them back to actually treat them. I will say after they've gotten their cells, after the first couple months, then it's really easy. I mean, it's making sure they're okay. That first few months, it's a lot of work, and so all of us are learning how to do this more efficiently. But it is phenomenal, but it's just you have to learn how to manage all this and get patients access.
Yeah, I think the other interesting point, and I'm curious where you all fall on this, is the one and done has been sort of the highly touted approach. But certainly for several of my patients, I'm putting on low dose IMiD maintenance a couple months after the CAR to try and prolong that remission, even if they're POM resistant. And I'm curious what you guys are doing.
Yeah, so I'm doing it more with if my patient ends up getting ide-cel, because there's more data with ide-cel and continuing with len maintenance after. And we also know that the response rates with ide-cel are a little bit lower compared if you look at that with cilta-cel. With cilta-cel, if they've gone into an MRD negative state, then I really don't necessarily put them on any image just as yet. I do think tools like MRD testing will be able to help us decide whether or not you need some kind of maintenance, because this is the first time, we like this one and done approach, but this is the first time in myeloma that we're doing this one and done approach. And we may not need maintenance in all patients, Sagar, but we may need it in the high-risk patient population. And that's where I think we don't have a lot of data. We need to gather more data. And in anecdotal patients, I do exactly what you do as well.
Yeah, I agree. So we actually have a clinical trial for radiation so that we can still try to keep it as a one and done. So we do PET scans, before and after. And if anybody has any extramedullary or plasmacytomas that are still lighting up, let's say 1 to 3 months after, we just do a low dose of radiation with my colleagues in the radiation department and then monitor. And we've had some pretty impressive results so far with that. Again, there's, immunotherapy effects that can happen, et cetera.
Right.
But I haven't used systemic therapy yet. But I agree, my high-risk patients who even get into CRs and are MRD negative, 6 months later, a year later, we're seeing them, with aggressive disease again. And so if there's a way to, the high-risk population, again, prolong this, we know that they still do better than anything else, but they don't do as well as standard risk patients.
Yeah.
So just to speak to that point, actually, we will be starting a clinical trial.
Yes.
And I think this really, I'm putting in a pitch here to study this more. And what we are doing here, Sagar, is we're giving patients, so these patients who get ide-cel, we've stuck with one CAR T cell because we didn't want a lot of others. And then what we're doing at the back end is a fixed duration of a bispecific T cell engager. We're going to do 6 months of elranatamab after They've had the CAR T cells with ide-cel. We'll see. We're just about beginning to accrue to this, and we'll see what that looks like.
Yeah, and I think MRD is always to me a bit of a two-edged sword in the sense that, in many of the trials, the day 30 MRD in my mind was meaningless. So is it 6 months? Is it 12 months? What is the time point that you use that has some value? Because we know in earlier lines of therapy, MRD does not correlate with cure. It just correlates with better outcomes. And how do you use that to make those decisions about maintenance that you're talking about?
Yeah, but right now I don't think I've used MRD to make those decisions because it's still very early data. I agree that the 1 month marrow that we do post CAR T cells, you really don't find anything. That's a tough marrow to do, and in general, that marrow is fairly empty. Looking at MRD beyond that, most of the studies we're looking at 3 months, 6 months, 1 year. And at least if you look at the cilta-cel data, what the cilta-cel data is showing us now is as long as you're having sustained MRD negativity for 1 year or 2 years, those are the patients who have that really long progression-free survival, and those are the ones who probably don't even need any kind of maintenance treatment. So I think sustained MRD negativity is something we're going to have to adopt in the CAR T cell space as yet. And I would say at least 1 year apart, but we need more data.